Welcome to White Coat Black Sheep. I'm your host, Dr. Civelli, and today I have with me Dr. Matt Bear.
Yeah, thank you.
Welcome, addiction medicine specialist.
Yeah, addiction and family and street medicine. So yeah,
How's that going?
really well. I feel like ridiculously blessed. To be honest, it feels like I cheated to get some bonus in life. Like,
I'm going to quote you right now.
Yeah.
You said, "My days all look good, man. I'm incredibly lucky."
Yeah, I stand behind that. I feel like honestly, I got like straight out of residency. I landed like a really good position, and Clinica has let me sort of like take every little brainchild I had and just run with it. And so when I came to them and I was like, "Hey, I want to start the street medicine, and we're gonna take a backpack and we're gonna take medicine out of the clinic and we're just gonna take it into the homeless encampments and see patients." I thought for sure they're like, "The hell you are," but they were very much like, "Yeah,
Fully
let's do
supportive.
that." Yeah, and then it was like, "Hey, I'm gonna start doing addiction treatment," and like, "Yeah, let's do that." So they've really every single step along the way, I've just been very lucky. And then because of I think the patients that we serve, it's just very like underserved and marginalized.
Oh, yeah.
And so that brings a ton of like just satisfaction, day-to-day satisfaction. Yeah. I mean, like, if you think about traditional like medicine and what that looks like in terms of your relationship with the patient and your relationship with their pathology, a lot of what you do in medicine is like, hey, I'm trying to prevent, right? I'm trying to prevent your A1C from getting so out of control that you lose your feet, or
Right. Like, I see you're trending up. What are you doing?
right.
Let's
So
talk about
it's a
that.
lot of that, like, hey, I don't want you to have a stroke when you're 60. And with addiction medicine and street medicine both, like that is flipped. And the interventions you make are having very immediate life changes. So like when you get someone started, and you've probably seen this working with like buprenorphine and stuff, when you get someone started on treatment, it's not just like, hey, I'm feeling better. It's like, hey, I got a job. Hey, I saw my kids for the first time in 3 years. Hey, like I'm not having those legal problems. So it's just very like, and that's every day. Every day you get to see people.
Instant gratification.
Yeah. So it's it's like legit rewarding. So yeah, it's
I
been
just
great.
love that. I wanted to experience that. I feel like I was looking for that exact thing. But when I graduated, I did telemedicine, and it just something about it was appealing to me. I liked that it was access to a doctor that people wouldn't otherwise have. Lake Isabella is pretty far from here, and it's, as you know, a very windy path to get there. I had a lot of the clinic patients there. Driving out there, no doctors go there.
Yeah.
And so, but really on the other side of that, seeing that population, I just felt like, okay, nobody was like, I was forgotten about, number one, because I'm at home.
Yeah, that's fair.
But I'm at a standing desk. I'm actually like, I was so serious about it. I had like 40 people on my schedule, and I was like, they would load me up, and then it would be like 10 o'clock, and then nobody's readied,
Yeah.
And in our world, readied, just, to anybody listening, would be, they have called the patient, their insurance is there, we have their phone number, everything's confirmed, and we have their chief complaint, so we know that they're not going to get a surprise bill, and like we can properly see them. So I couldn't call them ahead of time. Anyway, it was just really, I don't know, it was not instantly rewarding. It was not fun, or what I feel like I gave up everything to do. And I just was like kind of standing there with an empty bucket, so to speak. And
that sucks. That's like moral injury. And I think like coming out of residency, we're also motivated. And
I was motivated. Like, let's change the world.
Yeah, exactly.
I give up everything to do this. And then you're there like, oh my God.
I'm so sorry.
No one cares.
Yeah, we had the opposite experience, it sounds like. Like legit out of residency was like
completely different.
Very rejuvenating, and like very like I feel like I kind of woke up again after residency.
That's what I wanted. I feel like I'm just now.
That's wonderful.
Just now feeling that.
That's really good.
I feel like I've woken up and I can help people, and I want to. I have the energy to, and I know how to. And you just need to call me, like, like come on over. Just like you were so ready and willing to take on my patient. Like that's how I feel. Like if you need something, you just come on in. Like we've got you. You're gonna feel great.
Yeah, I think it's very easy to get dragged down into the bureaucracy of a clinic or the bureaucracy of medicine and billing and insurance and all that.
It was shocking.
Yeah. So, I think that's a very common complaint or common experience, right, for a lot of physicians. And legitimately, I feel like all of that sort of bounces off of me now because of the patients I'm able to interact with and the relationships. Like, that's another really critical thing about the way I see patients is that it is all about building relationships, whether it's like that person in clinic or that, patient out on the riverbed or, under the bridge or whatever. It's just like taking that time to build a human relationship.
They know you and the patients, like, they remember you, they know you, they are not worried. They know that you're going to be back.
Yeah.
If you maybe miss them that day, like it's just, it's really cool.
Yeah. So I think that sort of relationship building medicine is really protective towards burnout. Mm-hmm. So yeah, just food for thought, I guess.
That's such a good thing. Yeah. So like for a lot of my colleagues, as we get together, which is honestly not often, we're not, doctors are really not that social.
How can you be?
We're tired. I found most of the jobs that I've worked, like since graduation, just made me tired. And so I'm like, why don't I love it? Why am I not like so over the moon to like just show up every day? But then, okay, so fast forward, now that I'm here, I feel energized. So it's about like finding exactly where you're meant to be, what you're supposed to be, and just connecting with the field that you can really do what you're meant to do.
Yeah, to me, that makes perfect sense. If you're not getting something out of it, sort of that emotional feedback or something rewarding, then what the hell is the point?
People just take pieces of you.
Yeah. Oh, yeah. Absolutely. And especially in the field of medicine. And this is not exclusive to doctors. Mm-hmm. It's for everybody in the field of medicine. Mm-hmm. Like, there's always more to be done, and like there's always a call to be like, do more, be more. See
Your
more
list
patients.
is never done.
It never. Mm-hmm. So it's very easy to sort of lose yourself in medicine. I think you have to be very intentional about like, no, these are my. As much as I hate that.
I hate that. I'm a yes person. You're a yes person.
I'm very much a yes person. So you have to have like at some point like a boundary.
No.
Yeah, and I hate it doesn't come naturally to me.
Same.
But having 4 kids and my wife, it makes that much more doable, right?
What? You don't live at your clinic?
No. But when I'm in my clinic, I am in. Like, I feel like
totally
a piece of my clinic.
Yes.
But then when I'm at home, that's what I want to be too. I want to be at home and just dad and husband and not a clinician. So
I love that.
I've been very, very lucky to do that. So yeah.
I think that really shows too. I mean, you're always like, so like my experience with you is that you've always loved it. You are a piece of the clinic and it's just synchronous and it's infectious, really. Like, like
I don't know if that's good or not, but I don't know.
Infectious in a good way.
Yeah.
In a way you don't want to treat.
Yeah. So, no, it's been really, really good. I love the patients. I love this. I've sort of grown more in love with Kern County over the last
I know, me
5
too.
to 7 years.
And today was really gross, like aesthetically.
Yeah.
It was very foggy and cold, and everyone sounds congested.
It's so true. Yeah. But it's also, we don't get this type of weather very often, so I'm kind of embracing it.
Yeah, it's a little moody.
Yeah, very moody.
I embraced it.
I totally agree. This is good, like, read a good book.
Yeah.
Weather.
Yeah, but you probably read a lot of good charts today.
No, not too much. I'm not so. I saw like 20 patients. I had only morning clinic.
That's like a whole day for a lot of people.
Yeah, but a lot of my visits are follow-up, so they're pretty quick. And honestly, like, I don't even know if I ever want this out on the air, but it doesn't feel like I'm working most of the time because I'm legit. I'm just having conversations with people that I genuinely love and care about. So it really is. It feels like I'm calling me like, dude, what's happening? How's everything?
That's you and your purpose, though. That's what it
whatever
looks
it is.
like.
Yeah, it's really, really. It doesn't feel like taxing at all.
And that's exactly what it should be. That's what I'm just now tapping into.
Yeah,
and
tell me about that, by the way.
Yeah.
Tell me about the functional medicine.
Okay, so functional medicine, I think, is such a interesting new space. So with primary care, where we all started, family medicine, you can see everybody and you can treat anything. And it really gets complicated, especially if somebody has trouble getting into the clinic, because as a person who struggles to say no, like, I'm going to just like maximize the visit and try to see you for everything. But then the time slot does not allow. And then insurance doesn't pay you. So really it's like, I was just creating this burnout scenario, like not meeting the goals, not really helping a patient fully. You can't fix everything. It's hard to get people back in timely. There's a lot of things.
That's horrible because then you're failing everywhere.
I
right?
felt
You're
like I
failing
failed everywhere.
your employer or the boss. You're
Yes.
failing the patient.
Everywhere.
You're failing yourself. You're failing your friends. That's a horrible
And then
way
my
to
mom
exist.
calls and I'm like, I failed to answer. And then she's now
Right.
pissed off. Like, what about me? And I'm like, oh, well, I need to find myself. I need a minute.
Yeah, that's fair. I'm so sorry.
No.
I'm so sorry.
Well, I'm not alone in this, you know?
Yeah,
and
no.
and so sharing this whole like toxic cycle, really, this is what led me to where I'm at. So let's see, 2023, I looked into peptides. I went to this conference. I was in Grand Cayman where I did med school, and I was just swimming in the ocean, and I happened to meet this ER doctor who was a longevity doctor in functional medicine. So he's ER, and then he specialized into functional. And I was like, what is that? Just like you said. And really, in his case, he described it in his own scenario where he had an aneurysm in his brain, like around the pituitary, and he almost died. He was saved just in time. They put a clip, and then he was deficient of a lot of hormones, including growth hormone. And but he didn't know that for a while. He just was like, I feel horrible. Like I would rather be dead than feel like this. And he went to all these different doctors, and including endocrinology. They're like, oh, okay, you have a low testosterone, like really everything was low. So low growth hormone, everything. So he got onto replacement. He's like, oh my God, I got my life back. I got my life back. So from that moment, he just like, I have to do this for other people. And I don't think I know how to do that. I'm an ER doctor. So he went into functional medicine from that. It really is a subcategory. It's outside of the scope of what anything that we have learned. Like we have the primary working knowledge of the whole body at different ages. But when you are looking at like hormones and like the safety profiles, and it's like, yes, the paper, like we're looking at reference lab ranges, but then also there's subspecialty labs that you can do. There's spaces that you can, I don't know, I guess go more aggressive, like do higher doses or lower doses of certain things, adjustments that you can make, or supplements that you can do that really give people their life back.
Oh, interesting. Yeah.
Yeah.
So it's a subset of endocrinology, or no? It's
Yeah, I would say everything. So it's in the space that that is not the general like health maintenance and wellness. Like if you went to your regular doctor, they would likely say everything is fine if you're mostly fine according to reference range labs. Whereas we in functional medicine might have a different summary of your labs.
Okay.
Like you know, like how we'll look at hemoglobin on a CBC and the MCV. We can say macrocytic, microcytic anemia, your platelets, you know, are normal, but then there's nothing else that's on there. Whereas functional medicine is going to say, oh, I see your basophils are really elevated, or there's calculations that, you know, would kind of tell a different story. Or your hormones, oh, your estrogen is fine by reference, but then if it's just a E2 estradiol, that's not adequate. So it's just a very like a expanded, in-depth management.
Interesting. Yeah. No, I don't know that I've heard the term before. So
yeah, it's so longevity. You'll probably hear that term a lot. So aging is considered a disease. It doesn't get that term because too many people are affected. Everybody ages. If 100% of people are affected, then it's no longer considered a disease. You have to have a subset of the population. So everything that is pathologic is due to aging in a sense, right? So it used to work, and then now it doesn't.
okay.
Because something intercepted. So it's kind of just like looking into different angles of that. I mean, telomere length. Have you heard of?
Yeah, I
remember
remember like that, like the studies and stuff about that back in like the early 2000s and stuff. But it's not a thing I follow. So
Yeah. So you can check the length of your telomeres, and then you can see based on that, like if you change your different lifestyles or supplements, you can extend them. You can actually have them measured every 3 months.
That's wild. Yeah.
It is wild. There's a lot of Harvard studies that
So
have
what is
made
that?
these labs.
What does that look like in terms of like practice? So like, what does your day-to-day look like as a functional medicine physician?
Short answer is that it's longer visits.
Okay. Well, that's not a bad thing
No,
necessarily.
no, it actually is very pleasant. And I look into things like how are you sleeping? And I'm going to hear what you tell me, but then I'm also going to ask you, show me what your wearable data shows you. And me, for example, so my doctor used to ask me, how do you sleep? I'm like, good. Like, I think I slept good. But really, when I started using a wearable, I saw I had a lot of light sleep. I didn't have enough deep restorative sleep and REM. So I, made those adjustments. It was anything from like lifestyle changes, like stop looking at my phone after 6, put it away. No bright lights, no decisions, no fights, like nothing.
No decisions after 6. Oh my God.
No decisions.
I feel like that's when I make all my decisions. For real.
Well, if it's not affecting you and
Yeah.
and like your labs look good, you feel good, and your sleep is great, then carry on, right? But for me, it was keeping me up. Apparently, it was preventing me from that deep sleep, right? Like I wasn't unwinding enough. So, and I did that, and then I also started to exercise in a different way. Rather than like hit interval training, I would do like heavy lifting and less cardio. So for me, and also I started to have a lot more carbs. So
Nice, me too. It's going great. I feel great.
right. So like those little changes were pretty impactful for me.
That's awesome.
Yeah.
And
And
so now you sleep much better and feel better overall.
I do. I feel
awesome.
strong. Yeah.
That's good.
Yeah.
Yeah, sounds great.
I feel like after the sleep was corrected, that corrected like a lot of other things. But
Yeah.
and I went through hell. Like 2025 was horrible, but I felt fantastic.
That's good. That's really good. I feel like it's easy to really appreciate how much sleep can affect your day-to-day life. I mean, I feel like actually there's a lot of those little things that can really, really affect just how you interact with the world. Like chronic pain patients, I always think about, like if I have a pain that lasts more than, an hour or so, like it affects my whole day, right? It affects my mood. It affects how much I can enjoy a meal. It affects how much I can engage with other people. So then you imagine these people who have like pain all
the time.
every day. And it's just like, how do you like,
I would be so, well, I mean, you'd have to really check yourself.
Yeah.
Because I think I would be irritated.
Yeah. I mean, I think irritated is like just one of many potential emotions to have with that. Yeah, it's just so awful.
Yeah.
So, yeah.
Yeah, so stuff like that, right? Like, so just checking in with people, like if they do have like a irritated like symptom, and usually it's like the husband and wives come together, or I do see them separately, and I get to learn like what the real
the dynamic between
yeah,
them
because they tell on each other.
Yeah,
So.
I like that.
Yeah, but so it's just looking at data, extended data. Like I do gut microbiome tests, longevity tests.
So you had mentioned like that you had a patient who was on a buprenorphine product.
Yes.
So how does functional medicine fit into like the addiction space, the pathology of addiction?
Yeah, so we are invasive. I would say, first visit could be like an hour, it could be a little bit longer, just depends. But when we're looking into every category of like your sleep, your performance, because it's really about like you're optimizing. A lot of people, they show up, they're healthy, they're high performers, they're already they look like they're killing it in life. So, but they're like, I just know that I used to be stronger, or I used to not have these episodes of like anger, or I used to, right? It's I used to, and then. So that changes the space that somebody would see me for. Because you're fine until you're not. And it's really, so for this particular patient, now that I've learned a lot about the personal life, there's like a lot of social, I would say, triggers going on, like with his family dynamic. And then he had a performance issue at his work. He's a self-employed. So focus was a problem. He just felt tired all the time. He worked out. He could lift heavy. He was like doing as much as he could to really stay on a schedule, but his sleep was poor. And then I tried different like sleep aids just to temper or behavioral changes. We checked all the labs. Testosterone was low. We replaced it. There were just a few things, but like finally we realized it was kratom.
Yeah.
But I started out, I would say like 2 years prior to him. I didn't know what that was.
Yeah, it's sort of really taken off in the last couple
Crazy.
years. Yeah, so it was, it's been around for a while, but it really, honestly, in like the last, I would even say the last 12 months, we've seen a huge explosion of patients who are struggling with kratom. And it's a very strange chemical on its own, and it acts like at low doses, it sort of acts like a stimulant, but then at high doses, it acts like an opioid to the point where it's like you can overdose on it. And then you can just go buy it. Like you can go
At a gas station.
Yeah, totally legally, no restrictions. It's really, really wild. So yeah, we've had a lot of kratom patients, and it's really tragic. So
I had to learn, like, whenever you're going over like a medication list, like what stands out, right? Like you're kind of listening for certain things, like which ones are impactful for this patient. So for him, I had to just ask him directly. It was not brought up. And I was like, nothing else makes sense.
yeah,
And so just, so I have to go like, that's the part where I'm no longer like primary. I'm like, let's go functional medicine right now. Let's go a little bit rogue. Tell me your supplements and herbs. Tell me which teas we're drinking. Tell me like all that stuff.
Wow.
So I had to like learn like all of like the language, like ashwagandha, rhodiola, like let's talk plants and herbs right now. So there's a whole like repertoire of things that people dive into, and I know them all now. And
that's good.
Yeah,
there's a lot of them.
There's so many,
and they're not regulated the same way as
not
regular
at all.
meds. So if someone's like, "Hey, I'm on this dose," it's like, yeah, well, what does that actually mean? Because it doesn't. 25 milligrams of amlodipine is different from 25 milligrams of, thistle or whatever it is, because it's just not, it doesn't have the same regulations. So, yeah, it's a tough one. That's a tough one.
So like really learning how to speak to that type of patient. I mean, I would say that's really the type of patient that I would treat. Yeah. And a lot of them, they're like, well, I know I have diabetes, but I don't want to take this. And so like I feel like it's a gap that I can bridge, because it's like, look, here's what you're doing by not. So we talk like regular medicine first, always. Nice. But then the rest, it would be like, okay, so go ahead and take your statin, but then let's also add on coenzyme Q, because it's going to give you an extra benefit. Maybe they'll agree to like a lower dose statin. Mm-hmm. I don't know. It's a language. It's a reframing. Yeah. Like somebody, like they reject depression. I don't have depression. I don't have anxiety. That's for other people. And I get it, right? Because they're intelligent, like professionals. Doctors, lawyers, a lot of, that type of patient. Like, don't diagnose me with that. That's for other people, right?
Well, I don't know if it works that way with any other, right, illness. Like, no profession is spared pancreatic cancer or high blood pressure. So I don't know.
Well, okay, but it's happening, right? So like a lot of these types of patients, I feel like we do a lot of reframing. So like, okay, this is a nervous system issue. So you're too much in sympathetic overdrive. So let's get you back over to parasympathetic. And so I don't know. It's just it's a language.
Yeah, it's. I mean, this is my first step into the conversation of functional medicine. But one part I'm hearing is that there's shared decision making and patient centered care.
Yeah,
and so that very much
and overlaps.
A whiteboard. Mm-hmm. Oh yeah, it makes sense. Yeah, a lot of education. So, but that very much overlaps with addiction medicine and street medicine as well, because it's not about like, hey, I'm coming in with my agenda for your health. It's like, hey, I'm just a conduit to like medical treatment. And what is your plan? Like, what are your goals?
Exactly.
And how can I help you reach those goals specifically? Not my goals, but
100%. That's the same way I see myself completely.
Yeah, that's good. Yeah, that sounds fun. And that honestly, like, it makes sense that you're feeling more rewarded now professionally.
Finally.
Because it feels really good to like, I don't know, let someone else drive and you're just participating and helping in a meaningful way, and as opposed to you're dictating and composing and finger wagging.
Yes. Like you're going to die of this. Like, I mean, all right, we talk risk, like your risk of mortality is high if you don't change anything.
It's so funny. It's like, that is straight up. So when I first started doing street medicine, I thought, okay, I'm going to take like the high quality evidence-based medicine that I perform in clinic, and I'm going to take it to the streets. And then I got out to the streets, and the patient was like, what the hell? Like, this is what I want. This is what we're talking about. This is what I need. And I had to become, I was sort of forced to become patient-centered. And so then I took that philosophy back into this is when I was still doing primary care. I took that back to like my diabetic patients and was like, hey, here's like your A1C is 14. The guidelines say you should be this. We should start you in this medicine, maybe some insulin. But really, what do you want? Let's start there.
That's like a fail, right? That's like
100%.
that's overwhelming. Like,
Yep.
oh my God, like I just want to crash and like I'm gonna go to sleep.
Yeah. And what'll happen is if you do prescriptive medicine in that way, hey, you need to be on these meds. I'll send the meds for you. They'll say, okay, thank you, and I'll never see them again.
Yep.
Because they're not going to take all those meds, but they're going to be too embarrassed to
Yeah.
come back and not have
Fail.
done what exactly.
Yeah.
So then I found I was like, all right, like if the first step you want to do is let's talk about cutting a tortilla out of your diet, cool, let's do that, and we'll just follow up. And I feel like when you let the patients, when you really do all that hokey, patient-centered care, it really has better health outcomes.
It actually does. I know. I used to laugh at like I don't know, the way we're talking, really.
Yeah.
So I'd be like, okay, like marketing.
Yeah. Yeah. I remember being taught in med school, like all these tenets of good medicine.
Patient-centered care.
Right. And it's like, yeah, okay. Yeah. Like I know what to answer on the test, but then it's like, no, when you actually apply it in a real world experience, it's like
let the patients decide.
Yeah. It's life changing.
Yeah.
So, yeah.
Yeah. So I'm actually doing that.
That's all. Yeah. It sounds like it. So yeah. That's awesome.
Yeah, it's pretty cool. Or like diets. I mean, there's so many weird diets, and like a lot of people like bring out these like very restrictive things. I'm like, yeah, you're gonna lose some weight. Like, okay, you think I'm going to? I'm like, no, I know you're going to. You're going to. But like, can you sustain that? Like, is that good for your longevity? No.
Yeah.
So then that maybe would be when we talk about their telomeres.
lots of telomere talk.
No, we don't talk about it that much.
That's good.
Yeah, no, I think it is patient-centered.
That's awesome. Yeah, I think that's the way to be. I think that's what's missing, honestly, in a lot of medicine as a whole.
Yeah.
It's just like we sort of get taught to be prescriptive. We get taught to like, hey, here's the algorithms, here's what you do, and it's never like, well, okay, well, how do you present that to a patient? But then don't do that. How do you present that to a patient and a patient tell you no, and you still come up with a plan that's going to have that is.
Right. So there's an action.
Right.
Yeah.
Right. So how do you do that? And I don't feel like that's really focused on. It wasn't in my medical education.
It wasn't in mine either. Yeah. It's like I'm the doctor because I said so.
Yeah, I hate that. I hate that. Yeah. I don't like that. I don't like that power dynamic at all to begin with. But
yeah, it's kind of like parent-child, like because I said so.
Yeah.
And
yep. No, so we see that. So and that on legitimately like that does not work in addiction medicine. They're like. None of that. So it's nice because it's like it gives me the ability to not have to, like, I don't know, pretend to be someone's parent or to pretend to be this force that I'm not. So it's really wonderful. More people should do addiction medicine. So.
Well, okay. So on that, like, was there any like moment that you felt like hopeless about or hopeful that you're like, I know I can help this person or this one I can't help?
Yeah. I mean, it's, so, we see the field itself is sort of crazy because you have like these moments and they're very routine. They're very regular all the time of just like overjoyed experiences where just, like I said, patients are re-involving themselves in their lives and reconnecting with their family and they feel alive. But then because of the nature of the disease of addiction, like we also have a lot of death. And so we do see a lot of patients where it's like we can start treatment and then we lose them. We start treatment and lose them, and then we don't hear from them for a while, and then we find out like, yeah, they passed. And that really speaks to the mortality of the chronic disease of addiction.
Yeah.
But I've never felt hopeless.
Yeah.
Like
so you believe that there's always like hope for anybody that steps into the clinic. Like I'm not going to give up on this one yet.
Yeah. Oh yeah. So a lot of that, like what do we do with when someone is still actively struggling and they're not going to reach necessarily some goal of complete remission, right? So that's where harm reduction comes in, and that's where it's like, all right, well, if you're still like,
I like that term.
using illicitly, like what can we do so that you're using safely, right? So then there's a lot of what we do isn't necessarily medical. It's like, hey, how can we educate the patient on like safer injection practices or safer use practice, right? If you're going to use fentanyl, like you should probably use with a partner. And if you can't use with a partner, here's a phone number where you can call and just have someone on the line while you're using. So if you overdose, like someone can call 911 and we talk about Narcan and things like that. So even if someone is in the throes of active addiction, like we still want them to be safe, right? So even if it's like, hey, I'm not ready to stop using, and a lot
because
of people are not.
the future them would want to live. Like
100%.
the person wants to live. It's
100%.
such a chemical like
Right.
demon,
Yeah.
like a dopamine deficiency.
Yeah, absolutely. Yeah. So, and again, like our goal isn't to have everyone come in and be like, nope, like the way we want it is we want you to be 100% in remission or else it's a failure. That's nonsense. We don't do that for other diseases, right? Like my patients who have high blood pressure, many of them will have great blood pressure for months to weeks to years, all of a sudden to like lose that control. And that happens in addiction. And no one like gives the blood pressure patient a bunch of shit for like, dude, it's like, oh my God, no one's in tears over. It's like, yeah, that's how this disease works. That's how all chronic disease works. It's just there, waiting for a moment to pop its head up again.
Fine until it's not.
Yeah. It's the same with addiction. It's just like, it's kind of always there for the vast majority of people. It's just always kind of there in the background. If you can get it into that state of remission, hallelujah. But if you lose, right, if you have an episode of use or you kind of have a return to use, it
Or
doesn't mean
some trigger.
right. It doesn't mean it's over. It doesn't mean like you lost anything. It's like, yeah, that's the disease.
You
man.
had
That's
like a speed bump.
That's it. That's all it has to be.
Yeah,
And
so you can get right back on it.
yeah. And then there are the patients who are like, look, I don't want to stop. I want to use less or I want to use safe. And it's like, great. Let me help you as
that's
best I can.
interesting.
Let's do that.
Okay.
Yeah. Oh no, we have plenty of patients who are like still actively using. And so it's like, all right, well, what can we do to like prescribe in a way that keeps you safe? And what are other harm reduction principles do we need to help you utilize so that even though you're still actively using illicit substances, like, know you're going to be here right next week or the week after so that we can continue this battle together.
So like all of that stuff is just really, it's good to, I don't know, I guess it's good for me to hear it loud because like imagine, so fast forward a decade, all of those patients that were yours, like now they're mine in the nursing homes, right? So like if you're 65 plus, you can't, you're still some like enough dysfunction or weakness or whatever. So you can't live on your own. You have to be at a skilled place. They're at this facility now where every single thing is controlled and there's nobody who knows really how to handle it. There's no guidelines for it. And like a Norco 5 every, say 4 hours, maybe a max of Norco 10, that's really all that they're going to get. And so if they're going straight cold, they end up cold turkey, right? Like straight from the hospital where they're getting like IV morphine, from the street to the hospital for whatever reason, and then to the sniff, like there's no bridging.
Like taper.
There's no
that's awful.
No, and I had so many pharmacies, like say somebody's on a Suboxone program, they would, they have their usual dose, but then they're not going to get that because the pharmacy, they would tell me, I don't feel comfortable with this many MMEs. I'm like, I'm sorry, what is your name?
Yeah. No, it's really unfortunate. And I don't, we have issues with pharmacies and physicians sort of have their concepts of opioids and
it's horrible.
It is horrible, and I get it. The problem is a lot of pharmacies, they have to answer to the DEA, and if they're prescribing a certain amount of controlled substances versus non-controlled, they can get hits. People also have their own inherent biases, and they can treat patients a certain way. I will say, like just sort of kind of touching back in on the patient who's exiting the hospital on opioids and having zero tapering. Right. So that's horrible.
Yeah.
Like opioid withdrawal is the way we're taught it is like, oh, it's a bad flu. Like you get the sniffles and you get like body aches and goosebumps and you're going to feel a little anxious. That's bullshit. Like every patient I've ever had describe me opioid withdrawals is it feels that you cannot survive it. It feels like you're going to die. And imagine having that feeling, but also being post-op from a femur, right? Like a femur surgery or something.
Yep.
And you're 70 years old and you just got kicked out and you're
my
withdrawing.
patients.
Yeah, that's so sad. It's so sad. So that feels like bad medicine to me. So
it is so bad. And I don't know who can fix it because I feel like I don't know. I'm one person.
Yeah. Oh, yeah. No, it's a systemic thing. And I think there just need more conversations about opioids in general. We kind of all, we had this the huge opioid epidemic, which we're still sort of on the tail end of a whole other one.
I feel like it's not over at all.
No,
Like
I don't know that it ever. We're in a whole other one now, like with the fentanyl era and all that. But like, the pharmaceutical company, the medical community played this huge role in the opioid epidemic. And I honestly feel like we swung too far in the other correction, and too many doctors got very scared of the DEA.
So now they're like neglectful.
Right.
They're like, sorry, I can't. They just have to look away.
There
and
are
I can't do that.
many practitioners, doctors, NPs, PAs, who just draw a line in the sand and say, I do not prescribe these medications.
Yep.
Again, that's crazy because we don't do that. Imagine any physician who's like, hey, I don't prescribe metformin. I don't prescribe statin. Like, period. That's like,
it feels so
the hell's your
unethical.
job? Yeah, it does.
What is it that you do?
Yeah. So, yeah.
Yep.
It's like, and I think it's good for all of us to have a healthy appreciation for the risk associated with opioids, but it doesn't mean
you can't just abandon.
Right. No, absolutely not. I think that's bad.
Yeah.
That's bad medicine. Every medicine we prescribe, every intervention we enact, like, has risk and benefits. And like, you have to weigh those and have those conversations with the patients. But like, taking something off the table completely just feels like a bad idea. So.
Yeah. I feel like PMR doctors do pretty good. I actually got to work with them at acute rehab.
Yeah. Palliative
hospitals.
Also. Dude, palliative docs are where it's at. Those guys are so good.
Yeah. I got to work with one of our attendings as well.
Really?
Yeah. Learned a lot of good little tricks.
You should, at some point, if you ever get the chance, you should have a conversation with Rishi Patel, Dr. Patel.
Oh, I would love to.
Yeah, he's a palliative doc.
I want
who
to
does street
learn. I
medicine.
want to be better at it.
He's so good. He's a good dude, good human, and like really good advocate for his patients.
I would love that. I mean, I feel like I don't know if it was PMR or palliative, but I learned, like for fentanyl patches, because it does get kind of like crazy if you're chasing pain and you've got like the short acting and the long acting pain control, and then your pain's still not under control and you can't do IV based on the setting, and then so fentanyl patches were a pretty good option for a lot of people, but you have to have a little chubbiness to you.
Yeah. Oh, that's the problem. Yeah, one of the problems with fentanyl. Yeah, chronic pain's a difficult one. And the problem, opioids in chronic pain, again, they are necessary for many patients. And I think many patients need to be treated with opioids. And I'm very happy that we have those as an option. Again, it's not to say they don't have their downside. One of the ones that sort of I always butt heads with in the pain world is the hyperalgesia. The patients who have been on opioids for a long time and now they're like hypersensitive to pain stimuli. And it's really unfortunate because that's a very difficult thing to combat. You can't just take them.
It's like a sensory increased
they're like
sensory.
hypersensitive. Yeah. So then things that would normally like not hurt them become very like, like a nice little, like someone just kind of stalking you, hey man, how you been? Becomes exquisitely painful. And then every pain stimuli just becomes sort of amplified. They're more sensitive to it when they've been on opiates for a long time. It's like, yeah, well, you can't just stop opioids, so then you have to. That's one of the nice things about buprenorphine as a whole is you don't typically get that hyperalgesia effect. So if someone's on long-term buprenorphine for pain, then you don't get that effect typically.
Okay.
Downside is like buprenorphine as a pain medicine hasn't proven amazing. You know what I mean? It hasn't been like this.
Is it like a Band-Aid or like?
No, I mean, Band-Aids are great overall, but I mean, no, just like, it's just not as powerful, right?
Yeah.
It's just not as like, you're not going to get the same level of pain relief with say like a Suboxone or Belbuca as you would with like a Percocet or something. But that being said, there are plenty of patients who are on buprenorphine for pain long-term, and they're doing really, really well. And I think in Europe, they're much more likely to start patients on buprenorphine than they will on other full agonist opioids. So there's just room in the U.S. for us to be a little bit better about it.
I know. And really, I think that's like along the lines of the podcast. What are we doing well? Where is the space to improve? Because, I mean, I just can't accept that, like, we've nailed it in every category.
Which category did we nail it?
Your reaction, right?
Yeah,
so, like, I feel like we should be able to say that, like, where can we improve? And, like, let's try to do better. And it's more than just, like, academia. It needs to be, like, on our side, too, like, in real life, real time. Yeah, there's not all this evidence to support it, but we know that we can do better. And it's, like, we have to try. Like, where's the time and space to make that shift?
Yeah, I agree with that wholeheartedly. Yeah, there's tons and tons of room for improvement. I think the numbers would show it as well. But
oh, yeah.
Yeah.
Because I mean, I see suffering every day, and so like, I don't know. Getting old looks horrible.
I'm so sorry you feel that. I don't feel that way at all. I
Well,
mean,
because
I feel
you're not old yet.
I think I'm older than you by a
You
pretty
are.
good.
You're
Yeah.
older than. Well, I don't
Yeah.
know.
I'm 46.
Okay,
Like,
I'm
yeah.
42,
Yeah, I'm older
but
than
I'm
you.
talking like 80s.
Yeah. I mean, that's fair. Like, I sort of watching my grandparents sort of in the, the last decade or so, I would imagine, of their lives.
Mm-hmm.
And it is really, really, really tragic
It
to sort of
is.
see the amount of suffering day
Yep,
to day, especially with like cognitive decline and
that's huge.
not having insight into your own, like, what's going on, right? It's like things are happening in my body and in my mind, but my mind is not capable of understanding those
Yeah.
things and how frustrating that is. And
Yes.
so
So inflammation is said to be behind a lot of that, like Alzheimer's, dementia. So that's a lot of what I'm really
interesting.
diving
Yeah.
into. There's a skin test that you can do. I haven't done any yet, but I just learned about it. You can really profile Alzheimer's by a bunch of the different proteins.
Oh, interesting.
There's blood tests that I do currently order to look for different proteins in the blood for Alzheimer markers. Like the ApoE, and there's a bunch of other things. We don't go as wild as like getting CSF fluid, but
That's pretty invasive.
yeah, we
I
don't go.
guess.
Yeah. I mean, I'm sure some patients would, but like
Right.
we wouldn't. But still, there's profiles that you can biomarkers that you can look for in the cash pay world, where it's like, if money is not the issue, then let's look for it. So now we know that like the science is there to find and diagnose anything.
Mm-hmm.
Can you treat it? Well, it depends on the cause. Yeah. So like there's so much that I'm obsessed with it. That's kind of the direction, that I want to be like Alzheimer's, dementia. It tends to start in the 40s. You're in your 40s, and they're just kind of trending it, in all these studies, and it's so preventable. So
That's crazy.
It is.
Yeah,
They're finding,
this is news to me.
yeah, all of these like neurofibrillary tingles. They're just found in the brains, and they're finding these on these scans and the studies. So
That's wild.
yeah.
Well, at least we're doing that right. At least we're still like, for now, doing pretty good research out there. So
Quick question,
Yeah.
because I know we're almost out of time. On the premise of like addiction medicine and everything like addiction related, that area of the brain that registers addiction, even something as simple as like food or smoking, like, do you think it's okay, and do you agree with the principle that you're substituting a lesser evil for something else? Like, the addiction part of the brain is still active, but you have to take away something that creates a dysfunction in the personal or professional life. So you're substituting.
Yeah, I mean,
because it's still an active site.
So I think the way I view addiction, I think the most accurate view to take on addiction is that it is a very nuanced, complicated, multifocal, neurobiological illness, chronic
That's
disease,
so proper.
relapsing and remitting disease. The simple way I like to think about is the way we've sort of always been taught is, environment plus or minus bad choices equals addiction. And the reality is, like, having a better understanding of the neurology, neurobiology, of the genetics, is that it's actually incredibly complicated. And that equation is really like genetics and environment and socioeconomic status and childhood trauma and like a myriad of things. Choices are a part of that whole equation, but it's one part of many, 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 and that's what equals addiction. We like to focus on like, hey, the choices need to be.
We want to simplify it into one bucket.
Right. What we like to do is say like, this is your fault because you made choices.
Yeah.
But that's not accurate. And I think the world could benefit from seeing addiction as a more nuanced, and it's the same with like, think about diabetes. It's like, yes, your dietary choices play a role in that, but so do your massively. Your genetics play a role in that, and how you were raised as a child. Like, it's not just as simple as one thing.
Yeah.
And so that's how I view addiction as a whole. I don't know if that sort of fits.
No, it's complex, and I think
Incredibly.
we need to do a lot more work to address it from multiple different points.
Yeah, I agree.
Angles.
Yeah,
Yeah.
you got to tackle all those things.
Well, thank you so much,
No,
Dr.
thank you.
Bear.
You're such a champion.
I
I'm
enjoyed
so impressed.
it. Yeah, you are an example of success, and I just am so I'm grateful.
Yeah, thank
Grateful
you.
to have
I'm
had you
so
on.
fun to be here. Thank you.
Until next time.
Yeah, thanks.